Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizers for inviting me to this interesting symposium. The title of my presentation is Platelet Function Testing in Daily Clinical Practice, and I will illustrate that with key clinical cases. This is my disclosure. It should be noted that the Heart Center, where we have done all this work, is located in the midst of Germany, and this is a region that is characterized by an increased cardiac morbidity and mortality by more than 20% above average levels in Germany, independent of patient's age. It's a heart center without in-house cardiac surgery. The annual frequency of PCIs is about 250, and that for ACE patients about 150. You know that routine measurement of platelet reactivity has not been widely implemented in the guidelines. There are no large-scale trials demonstrated that adjustment of antiplatelet treatment based on ex vivo platelet reactivity testing leads to improved clinical outcomes. Platelet reactivity, and we also know that, is a major driver for stent thrombosis, MI and cardiovascular mortality. Therefore, mitigation of this determinant by P2Y12 inhibitors should result into an optimal treatment strategy. And I will skip to case number 1. So it deals with a female patient, 77 years old, diabetes, and notably a history of recent gastrointestinal bleeding. What you see here is an acute STEMI, so you see the occluded artery. So we recognized that, you see it here, and we could achieve a good result. The right coronary artery was tortuous and also showed a high-grade lesion proximal. We have also treated that. Now with respect to the history of recent gastrointestinal bleeding, we left the patient with clopidogrel according to the guidelines. We did no verify now testing here in this case. This is case number 2. It's a 73-year-old patient with acute STEMI, and as you see here, it's apparently a posterior infarction that is prone to additional complication, which is shown here by the pronounced ECG alterations. And you see that the heart rate is very low, below 50, and it's a beginning high-grade AV block. So we first implanted a pacemaker and then did the angiogram, which is shown here. We could document that it's an ischemic cardiomyopathy, and you see here that there's a proximal occlusion of the circumflex artery. The right coronary was also diffusely diseased and showed 2 high-grade lesions here, very proximal. So we were successful to cross the occlusion and to achieve a good result by stent implantation. So the patient was stabilized, and you see here with the ECG that we also had a complete resolution of the ST elevation, giving evidence of a good prognosis of that patient. We also did a verify now testing here, and as you see here, the PRU value was 302 with clopidogrel, and this was changed then at this time point to Ticagrelor. And this is a summary here on the topic of high on-treatment platelet reactivity. We have already heard that there's a clear association to adverse clinical outcomes. And here is a list of a couple of important papers. They report about a cutoff value of about 235 PRU that appears to be prognostic for subsequent thrombotic events. Notably, there's also one recent paper by Ahn and colleagues who reported for a subgroup of STEMI patient, and he reported about a cutoff value of 272. Now back to our patient. So you see here the right coronary artery, we have also repaired that, and we did a follow-up of the Verify Now test. And you see here with Ticagrelor that we could significantly inhibit and decrease that value here to 82. This is case number 3. It's again a patient with a posterior infarction. He also had a preloading with clopidogrel in the emergency room. Here you see the angiogram. It's a peripheral occlusion. It could be easily corrected here with stents. And here you see the PRU value with clopidogrel. We have also here modified to Ticagrelor. And you see here 5 hours post application of Ticagrelor, a markedly reduced PRU value. Now this is a summary of the antiplatelet effects of Ticagrelor in a high-risk group, in a subgroup here with high on-treatment platelet reactivity. And you see here it's a body of 18 patients, and you see a mean value here on clopidogrel with 271, and we could nicely reduce that here and found a mean value of 43, which is in very good accordance to recent data published by our colleague who had the last talk. Now, case number 4. It's an acute STEMI due to stent thrombosis. It's an older patient. He is 77 years old, and he had had a stenting of the proximal LAD 10 days before and was treated with clopidogrel and aspirin. And the Verify Now testing at this time showed a value of 202. Now we had the problem of acute stent thrombosis. This could be corrected. I show you here the final result. And we did again a measurement of the Verify Now test. And you see here we had an even marked elevated value of a PRU of 341. So this seriously raises the question to the compliance of the patient, or whether there are maybe absorption problems with the patient. So the patient was put to Ticagrelor, and we sent the patient to cabbage surgery to the next heart center. There the patient was stable after the procedure, and after several days he refused to have the operation, and finally he was sent home. However, as you see here, 18 days post-LAD recanalization, the patient came back to our hospital, and he again had a re-stent thrombosis at the proximal LAD. So we did a control of the Verify Now test, and you see here now with Ticagrelor aspirin that it was a relatively high value of 275. Again, we had the concern of compliance or absorption problems, and this time the patient was sent to surgery and operated the same day. He does well now. This is case number 5. It's a complicated case. A patient, 57 years old, and this patient had been already stented at the LAD 1 year before and 6 months before at the circumflex artery. Now he came with an acute STEMI due to stent thrombosis. When the patient had been in our hospital 6 months before for stenting of the circumflex bifurcation, he was treated with prasugrel, but this had recently substituted by the general physician to clopidogrel and aspirin. When the patient came now, he had a PRU of 314, and notably, this patient also suffered by myasthenia gravis and had an immunosuppressive therapy. Let me show you now the angiograms. And you see here, this is the target lesion of the circumflex. We also see a severely LAD here in the stent region. And we try to reconstruct that I will show you that we succeeded in that and we could achieve a nice result, which is depicted here in two projections. We put the patient back to prasugrel aspirin and look at here, the Verify Now testing showed very good results. We were very content with that. Also, importantly, the patient was clinically stable. So we followed him closely and also integrated an invasive control 3 months later. And as you see here, we saw a brilliant result of the circumflex and the marginal arch. And also you see here that we have a very good filling of the LAD in contrast to the previous angiogram 3 months before. So probably the therapy with prasugrel and aspirin may also help to remove thrombus material here at the LAD. We also did work with the Verify Now test, and you see that we have a constant, clear inhibition of that value. However, unfortunately, this is not the end of the story. So it's 14 months later, the patient came again. And this time he came with a cardiogenic shock due to another stent thrombosis. And as you see here, the circumflex artery and the marginal branch were occluded. You see here a very high-grade LAD stenosis. And I really have to say that the patient came too late in our hospital. So it was possible to repair the LAD, which is shown here, and to reopen the marginal branch. But it was an excessive thrombus formation, and therefore we could not rescue this patient. Importantly, when we contacted the wife of the patient, it was reported that the prasugrel medication had been finished 10 days before, and this was the advice of the general physician. And we only want to comment that here, how important it is to carefully follow these patients. And this is the last case, it's case number 6. It deals with another important scenario. It deals with the withdrawal of antiplatelet medication and the recovery of platelet reactivity. As you know, in the guidelines are widely based empirical concerning the time of withdrawal of antiplatelet drugs, and for Ticagrelor, there's the advice to withdraw that for 5 days. Here we had the scenario of a patient that had been stented 3 weeks before at the proximal LAD and now had the need for abdominal surgery. And as you see here, by doing Verify individual testing, we could follow the platelet activity. Here you see the percent of inhibition with the red bars. Here you see the gray or dark bars. These are the PRU values. As you see here, specifically in that individual patient, the PRU values already were larger than the value of 200 units here at day 3, so that we could give the patient to operation already at day 3 and did not wait the full 5 days period as recommended by the guidelines. So in summary, our patients, especially those with acute coronary syndrome and STEMI, adjunctive Verify Now testing was useful to identify and mitigate high on-treatment platelet reactivity, identify non-compliance, and identify unauthorized treatment changes. The use of Verify Now testing led to treatment modification in 7 of 69 patients, that means in 10%, and confirmation of low platelet reactivity not requiring further action in 90%. Platelet function testing for individualization of antiplatelet therapy, that is to mitigate high on-treatment platelet reactivity, may be considered in selected patients with stent thrombosis or those undergoing high-risk PCI. Regarding the waiting period for surgery, the same tool may be cost-effective by shortening recovery time after antiplatelet discontinuation and associated pre-surgical length of stay. So in conclusion, in a retrospective analysis of a real-world application of platelet function testing, the Verify Now test facilitated the personalized choice of P2Y12 antiplatelet therapy while still allowing compliance to treatment guidelines. Thank you for your attention.